Okay, so my last paper session, they put me with all Norwegians, and now they're doing it again. So I think I'm onto something here that I'm going to see how many paper sessions I do, and I'm with all Norwegians. But they know a lot about patient preferences, that's for sure. Okay, so I'm going to talk about measuring patient preferences, maybe from a little bit different perspective to complement what Cornelia was talking about, more from a utility perspective. So I'm going to talk a little about why they're important, methods for measuring them, and then some issues of validity. We've talked a lot about shared decision making already. And the perspective that I'm coming from here today is one that's a little more quantitative maybe, but still shared decision making, and the idea that risk and benefit information is provided by physicians or by epidemiologists from the medical literature, et cetera. And then preference for outcomes are provided by the patients, and that information is integrated to inform patients about a recommendation based on their own preferences and what we know about risks. And then the patient makes the final choice. And this stands in contrast to the biomedical model where the physician looks for disease, tries to find disease, and then tries to fix disease without the patient really being involved. So last night, Warner mentioned that New England Journal took a long time, or maybe a very long time, to come around to patient preferences. And this is the first paper, very important paper, I think, that addressed this problem of patient preferences in the New England Journal of Medicine. And it was the fallacy of the 5-year survival with lung cancer. Barbara McNeil, Ralph Weichselbaum, and Steve Palker, who've done just a ton of excellent work over the years. Back then, the gold standard for treating lung cancer was that 5-year survival was considered the gold standard outcome. And early work in the 1970s showed that if you survived 5 years, you were more likely to survive 5 years from surgery than from radiation therapy. But there was this high rate of operative mortality with surgery. So you could think of this problem as, with surgery, most people lived a long time if they made it out of the operating table, but a lot of them didn't. And with radiation, no one died immediately, but their chances of being cured from lung cancer were much lower. So they might live 4 years, 3 years. So you see the point. So if you lived with 5 years with lung cancer, the chances of recurrence were close to zero, so it's considered a cure. And so physicians thought that this would be a great outcome. It has a lot of face validity. If you live 5 years, we'll tabulate you as a 1. If you live less than 5 years, we'll tabulate you as a 0. And then we'll decide on what treatment we're going to give you based on this. And if you ask patients, they kind of, that sounds pretty good to me, which points to something to be concerned about with empowering patients, which is that how you ask them questions or present information to them might affect what they tell you, and it might not always be correct. So what Barbara McNeil and these others on the paper realized was that this was really implausible that this was a good outcome measure, because if you look at this graph, this is survival, and this is the value you put on survival or utility. What it means is that you put no value on life up to 5 years, and then it jumps up, and because you're coded as a 0 here, then it jumps up to 1, and then anything more than 5 years, you don't have any added value. It's not valuable to you live beyond 5 years. So they said this is preposterous, basically. Yeah, so what they did is they actually set out to measure patient preferences and measure what we call utilities, and combine this data with survival statistics, and then they evaluated which treatment alternative is most consistent with patient preferences. And so what they found, they asked 14 lung cancer patients, and they found that their utility function wasn't like a step function, but it was like this, that they really valued immediate survival a lot. They wanted to live, the next year. And then it tapered off a bit. It was still valuable, but it became less valuable. And when they used that data, they concluded that radiation therapy was a better treatment for patients because it was more consistent with their utility. And this was really a wake-up call that patient preferences matter and make a difference. One other thing about this example that I think is important is that they did something called the divide and conquer strategy. Rather than just asking holistic questions, they broke the problem down into digestible parts. So they said, they gave them these questions about different survival durations and different risks associated with living those links. And these simple questions were then put together to construct this utility function, which then informed the decision. So this strategy means that you, instead of thinking that everything you get from the patient is valid, you need to break everything down to little small bits and then put it all back together, and that'll help inform your decision. So I'll just run through some methods that are currently being used, and I'm going to limit the discussion to what choice-based methods. So these are all stated preferences where patients state whether they prefer option A or option B. They don't do a rating scale or say, I like that, it feels good, that's great, or thermometers or whatever. They just make a choice. That is probably more consistent with what they actually do in the medical environment. They make a choice. So the first thing I'll talk about is conjoined analysis, and particularly one type of conjoined analysis called discrete choice experiments, where you're just given choices and then some direct elicitation methods. So a discrete choice experiment, a conjoined analysis is a general procedure for valuing attributes, but a discrete choice experiment means that the outcome that you're measuring is choice. So you're selecting option A or B or more. And what is done is that health is characterized by different attributes. The attributes have different levels, and these different combinations of attributes and levels form health scenarios. And these scenarios are then paired together to make for choices that patients select to say, I like this one better than that one. This is an example from Mark Sculfer's work with prostate cancer. And here's option A, diminished libido in both, option A and option B. Here's option B here. And you can see which of these different ones are the same. Ability to maintain erection, they're both the same, but there are differences. You have less energy with option A. Option A costs more, but option A has a little higher life expectancy. So you're making these trade-offs. You look at these options and you decide which one you want. Advantage of this procedure, it's simple and it's easy for patients to understand. It's often touted as more flexible than other methods, but one problem with it is that it very quickly balloons into a large number of choices. So if you in that last example, the choice set was size 2. You were comparing option A and B. So this would be 2, and there were 5 attributes, and I don't know how many levels he had in that. Maybe some of them had 6 levels. You get to these huge choice sets, so you have to pare everything down. And what actually ends up happening is that you do these fractional studies where you do make assumptions that are less flexible like other methods. So there's no free lunch with that. The other issue is that the choices are not in the context of risk. And I'll talk a little bit about that. I wanted to get a show of hands for this problem. So Peter Fishburne and later Milt Weinstein and others pointed out that asking people riskless questions may not always give you the information that you need. In the medical context, people make decisions under risk. They're facing differences in survival. They're facing different probabilities of having pain or discomfort. And so they might have different preferences in the context of risk. So if you look at this first option, suppose you have a 50% chance of a year of life in severe pain and a 50% chance of 10 years of life with no pain. That's option A. Option B is a 50% chance of 10 years of life with severe pain and a 50% chance of 1 year of life to no pain. With no pain. How many people prefer one of these options pretty strongly over the other? Okay, some people. So, right, so most people strongly prefer A. Right. And so what Fishburne pointed out was that if you just use conjoined analysis, then you should be indifferent, and you thought that was a good representation of your choices under risk, you should be indifferent to A and B. But most people aren't, which means that we need to consider risky choice also. We can't just do, we need to supplement with some risky choice questions to understand. This has to do with this, how your utility function changes with choice. But that's just to point out with a thought experiment that you need some supplemental data.
Say your last sentence again, it shows that your preferences switch with.
Okay, so it shows that you strongly prefer one option to the other. And because you strongly prefer that option, the values that you would have collected in a riskless environment can't fully represent your preferences because those values would suggest that you are indifferent. It has to do with the probability marginal distributions. I don't want to get into it, but it's...
No, I was trying to understand, and now I get the connection.
Yeah. So it's just an easy way to see, like, hey, you know, risk matters. It changes your preferences, and it needs to be considered. Another choice technique that's used is the time trade-off, which really examines one's willingness to live a shorter but healthier life. And so it asks someone a question like, how many years of life in full health are equivalent to 20 years of life pardon me, with back pain? And you then form a ratio of the number of years in full health, a fewer number of years that you're willing to live in full health that become equivalent to living a longer life with back pain. And that ratio reflects the value that you put on life with back pain.
No, this assumes no volition during that period.
I'm sorry?
So for that 20 years of life with back pain, one scenario is you could do something to fix it.
Right, so this is just gathering your values. So it's hypothetical. You could, but you want to make clear in when they're answering the questions that it's unfixable in this example so that it's constant. You can also expand this out to include many different dimensions of quality of life. I'm using simple examples here, but you could use all sorts of different domains of quality of life.
Wouldn't different people have different sense of whether they could exert control?
You mean whether they
So
could
someone
cope
who's
with
totally,
back pain?
No, someone who's totally type A, so I'll figure a way around that.
Yeah, it's possible, but that would be sort of circumventing the procedure. Yeah, sir. You mean like a CEO of a company or something?
No, the whole point is that this long period of time where you have a fixed thing,
Yeah.
that assumes that you can't exercise, get physical therapy, nothing is going to help you. But will
Right.
someone really believe that?
Well, they have to believe it to answer the question. They have to consider it as a possibility. They don't have to think that it's actually going to happen to them. They just have to be able to say, okay, I'm imagining I have this terrible problem for this really long period of time. Someone else had a question over here.
Yeah.
Yes. Yeah.
How stable are these under different circumstances? Do you have a sense? I mean, one of the famous statements is how people regard their choices when thinking about it in theory versus when in the center of it. And I think there's been some studies about obstetrics.
Mhm.
The idea of painless is a really good idea. I mean,
Right. Yeah. So this is all. All that I'm talking about today is what's called decision utility, which is the utility of a prospective decision.
Your utilities and whether
Yeah.
these, when you stress them, do they hold up or have people done that yet?
It does vary by context and framing. I'm going to talk a little bit about that, and Les has done some excellent work on that too, and different ways that you ask the questions or produce different results.
I think his question was whether hypothetical health states hold up when the person actually gets into.
Oh, in terms of revealed preference, yeah. Well, that's an important question, which is, do what people state in stated preference agree with what they actually do in real life? And I think that if you look broadly at this type of work, there is variation with, outside of health in particular, mostly in situations where there's where you might be socially shunned for saying that you like certain things, and then they observe people and they behave differently. But if you're talking about living in bad health states, there's not a lot of social pressure to say that you would really like to live with back pain for 20 years.
But I think there are some cases where they change their mind radically when faced with the pain.
That's true. Yeah, I think.
And
Yeah.
I just wondered if you
Yeah.
had some sense of how these various methods compare when you get into the realized states.
Yeah, I mean, there's been some work on that, and if you some data suggests that patients who are experiencing the state are less bothered by it than people who haven't experienced it yet. Yeah.
So, for example, people would, if you ask people without a colostomy, what kind of utility would you have for having a colostomy? They'd say, I've never wanted a colostomy. But if you have people who have the colostomy are doing fine with it, it doesn't.
Worse the opposite in those cases.
Yeah, exactly. So it can work either way.
So people with experience are less fearful than
Yeah.
people without the experience.
And there's a debate about what we should do about that, because some people believe that we should use experience utility, which is what people experience when they're in the state. And others believe we should use decision utility. An argument for decision utility is that most decisions we make in life are we've never experienced before. When we decide to join the Army or go into college, we've never been to college. We've never married the person we're going to marry. We don't know what's going to happen. We've never been to the restaurant we are going to go to. Yes?
On that topic, some of the work that I've been engaged in talks about just that these are things that people don't have a lot of experience in. So, for example, if someone asked you about a traffic ticket, you would be able to respond based on experience, which is usually very different than a decision you would make when you've never experienced it.
Right.
Which is in some cases why doctors and patients make different decisions, because doctors experience virtually many things that patients never experience.
Right. Yeah, I think that that's important, and particularly in the elicitation. Les's software that he's developed tries to really get at the issue of multimedia presentation so that you can really show people this is what it's like. And our patient interviews where they discuss what their daily life is like. I think that's important to really break it down for people, and this goes back to that divide and conquer strategy that you're right, people probably are not very good at, if you just use a word like back pain, that won't be a very easy thing for them to understand, but if you have a back pain patient, a video of them showing what they can and can't do or interviewing them about their daily life, it becomes better.
The issues why people make different decisions when they're actually there, because if they don't have the experience, there's more, and these are relatively rare events.
Right.
That they will overestimate
Right.
the risk and the potential consequences.
One other
Yeah.
quick example is that doctors are more negative about electronic mail with their patients in advance of using it
Than they are once they use it. Yeah. Yeah. Right, so before I move into validity and biases, the last procedure that's often used is this standard gamble. And the patient is put into a hypothetical situation where they're considering a possible treatment for their problem. Oftentimes, if you're using experienced utility, for instance, a patient's current health, you would summarize their health using some type of health classification system. And then that would be their current health, which would go here. And it would describe the different domains of health. If you're doing a hypothetical health state, you would describe the state here. And this is, your options are what's called the sure thing, which is that you stay in the state that you're trying to value. So you stay with back pain. So here's your option. Option A is stay with back pain. Option B is a treatment that has a probability P of returning you to full health, no disability, no problems, for however long it's set a time. And it has a complementary 1 minus P probability, though, of perioperative death. So maybe a 1% chance of death, a 2% chance of death. The idea is that this is your quality of life probability, that the better this health state is, the less risk you're willing to take to get out of it. And so P will be very high, close to 1. And when the state is very bad, you will be willing to expose yourself to more risk to get out of that bad state, and so P becomes lower. And so it's sort of a measure of your quality of life in that health state. And oftentimes it's presented, Les talked about this earlier, in a grid format which shows people who did well, the happy faces, and the people who who didn't do well, the blackened squares, and you can make your choice that way. So I also wanted to talk a little bit about validity. Unlike most areas of measurement, questionnaires where you talk about things like construct validity and predictive validity, this is very operationalized, and the concepts are very operationalized. So it comes from a different theory of measurement, what's called the representational theory, and that's the idea that the numbers that you get from the exercise, from the standard gamble, the time trade-off, conjoint measurement, should faithfully represent your preferences, meaning that if the quality of life probability of standard gamble is greater for health state A than for health state B, then you should prefer health state A to health state B. And so what's done is this kind of comparison between what people should do and what people actually do to see how valid these models are. So the focus has been on testing to start with what are called normative models, or what would a rational person do in this situation. And then when we find that they deviate from that rational approach, we revise the model. We come up with a descriptive model that accounts for that effect. And then we have a more valid representation of their preference. So what are some findings along those lines? Well, one is this idea of probability weighting, that people don't treat probabilities as they're given in the choices. So in the standard gamble, people behave differently than is given by how a rational person would behave given that probability.
So you mean they don't believe the probabilities?
Well, no, they just, I'll explain a little right now. Yeah, so, so here we have a graph. Here I've plotted 4 studies. There's probably 20 now, and they all look very similar. Here we have the probability that was given in the choice for the better outcome. Think of a 2-outcome gamble. Maybe you win $100 or you get full health, whatever it is. That's probability P. 1 minus P is some bad outcome. You don't get any money, or you die on the operating table, depending on what the outcome is. And here we have the weight placed on that probability based on studies. So what we find is that people tend to overweight the small probability of a good outcome. This is one possible explanation for why people play lotteries, is that they overweight the small probability of this minuscule chance of winning. And then the curve kind of flattens, and then they underweigh the large probability of a good outcome. And some people have postulated that maybe that's an explanation for why some parents are unwilling to vaccinate their children, because they underweigh the probability of the good outcome and overweigh the probability of the bad outcome from the vaccine. Anyway, but if you give people stated choice questions and then you measure this parameter, this weight, you find this very consistent pattern. And it doesn't matter whether you're looking at, here's a study on spinal cord injury. The outcomes were money in this. The health state here was chronic low back pain. And in this study, it was life years. You get the same result. Yes?
Is the concept of weighted probability supposed to be dependent on the way you ask the question, or is it only supposed to be dependent on the true risk aversion type of effect?
Well, it's sort of like an aversion to chance rather than risk, as traditionally thought. But I guess the first part of your question was,
I could imagine phrasing a question looking for the white swan versus the black swan.
Oh, is there a framing effect?
And yeah, and so is the weighted probability concept in the literature supposed to depend on this sort of phrasing as well?
To some degree, I'll talk about this in a minute, but if you frame outcomes as losses, you get a slightly different weighting function than if you frame outcomes as gains. Well, no, you get the same shape, but you just get a slightly different, you get more nonlinearity, or slightly more under one than the other. Okay, so but you're bringing me to the topic of loss aversion, which is another one of these biases, and that's this idea that under the normative theory, you're just looking at final outcomes, and you're saying this is a better final outcome, and I'm maximizing my best final outcome. But what we find is that what people actually do is that they have a status quo. They view outcomes with respect to a status quo. So they say, this is where I am now, or this is my frame now. And then some of these outcomes are better than that, and some of these outcomes are worse than that. The outcomes that are better are gains. The outcomes that are worse are losses. Losses loom larger than gains. So your value function is more sensitive in the domain of losses. So it decreases more rapidly. Losing the subjective discomfort of losing $100 is more than the joy from finding $100 on the street. And this is sort of like a kink in the value function. Another bias that affects some methods, like I've already mentioned this with respect to conjoint measurement, but also the time trade-off, because it is a riskless procedure, is this idea of utility curvature, that maybe your utility function is concave like this, and that would mean that your utilities are actually higher than you're measuring, because these methods like the time trade-off and conjoint measurement assume that your utility is a straight line. So here's just the list of these methods: discrete choice, time trade-off, standard gamble, and the different biases, or some of the different biases, there are more, that they're susceptible to. What's interesting is that I didn't put this in the talk, but there's a couple of papers out now that suggest that these biases cancel each other out, and the time trade-offs may actually provide a more valid way to measure, because one makes utilities higher and the other makes them lower. So what are some of the solutions to these biases? One is to use discrete choice. This was a strategy by Moss and Walker. They used discrete choice to get all these different values for health states. And then they minimized exposure to probability weighting by using very simple risk questions that they could correct for probability weighting to get at this problem of their attitude towards risk. You combine those two things and you get more valid utilities. Another option is, like I mentioned, is to use the time trade-off, which may have biases that cancel out, and there's been some studies on that. And a third option is to incorporate some sort of dynamic online assessment tool where you can show people their discrepancies and say, hey, look, you said this here, but you said this here. And then they can resolve their inconsistencies and say, well, this is what I really mean. Now that I understand what you're saying, that's called construction of preference. So a preference construction tool that can mitigate these biases through multiple frames, showing them where they're inconsistent, et cetera. So just to summarize, empowering patients involves understanding their preferences for treatment. That's not an easy thing to do, and it requires understanding their biases and overcoming their biases. Preferences do affect treatment choice, and there are multiple methods for eliciting preference. So that's it. Thanks.